I'd now like to welcome our host for the session, Kathy Amendolia, Chair of the Board of the Canadian Breast Cancer Network.
Thank you, Bakun. And welcome again, everyone, and thank you for joining us. I'm pleased to welcome Dr. Anna Wilkinson, who is joining us to answer all your questions about post-treatment and survivorship care. A little bit about Dr. Wilkinson. She's a family physician with a special interest in oncology. Dr. Wilkinson divides her clinical time between caring for medical oncology inpatients and academic family practice. Anna is an associate professor, program director for the PGY 3FP oncology program, and regional cancer primary care lead. She authors and edits the Oncology Briefs series in the Canadian Family Physician Journal. Anna's research interests include the intersection of cancer care and family medicine, specifically screening and survivorship care. In her spare time, Anna tries hard to keep up with her 4 teenaged athletic daughters. Dr. Wilkinson, thank you for joining us this afternoon. It's a pleasure to have you with us today, and I think this will be a very busy afternoon session. So,
thank you so much. I'm looking forward to it.
Great. We are still waiting for participants to submit their questions, and Bakun will be monitoring that. In the meantime, we have, as Bakun said before, some submitted questions. So we're going to try and cover as much as possible. I'm going to start with one of the questions. And as we all know, patients ultimately go on some form of treatment when they're diagnosed with breast cancer. And one of the questions is around the common side effects of hormone therapies, such as tamoxifen, and what are some of ways to deal with these difficult side effects.
Great, thank you. So yeah, I just want to make it clear before we start that I am a family doctor and not an oncologist. So if there's any really oncology specific questions, I'm going to direct those to you, to your medical oncologist. But I think family doctors have a really big role in survivorship care for breast cancer patients. And so I think getting the family medicine perspective is really a helpful thing. So in terms of endocrine therapy or hormone therapy, not all patients who've had breast cancer will be on these medications. You have to have a hormone-sensitive breast cancer to be on or to get benefit from a hormone treatment. The way that I think about endocrine therapy or hormones is basically that some breast cancers have what's kind of like a little light switch on them. And when there's estrogen around, that prompts the tumors to grow. It acts to kind of feed the cancer, if you will. And so what hormone or endocrine therapy does is it turns off that light switch and blocks the estrogen supply so that the cancer is less likely to grow and less likely to come back. There's 2 main kinds of endocrine therapy. So tamoxifen is one of them, and aromatase inhibitors are the other sort of major class. And so each of those has slightly different side effects, but they all work by essentially shutting down the estrogen or lowering the estrogen levels in the body. And so a lot of the side effects you'll get will be related to not having as much estrogen. So for women, the primary side effect often is things like hot flashes and vaginal dryness. Those are really common. And then there's more specific side effects based on which class of those drugs you're on. So I don't know did you want me to speak about both of them or just one class for now?
I guess the both. What are like some of the difficult side effects? I think they share common side effects. So
for sure,
the highlighted one specifically.
Okay, so tamoxifen works by sort of partially blocking the estrogen receptors in the tumor. So it's a funny drug because it kind of it acts as estrogen a little bit, like it makes the receptor work a little bit, but it stops actual estrogen from coming in. And so the benefit of tamoxifen is that actually makes your bones stronger and makes your cholesterol lower. The bad side of, or the side effects of tamoxifen are that it causes that vaginal dryness, hot flashes, and two really significant side effects, an increased risk of endometrial cancer, so a thickening of the endometrial lining, and an increased risk of blood clots. In terms of the aromatase inhibitors, those work by blocking the testosterone that's made from your fat cells in your body, stops that from converting into estrogen. And so they tend to block estrogen more strongly than the tamoxifen. And so again, you'll see vaginal dryness, you'll see hot flashes, you see a lot of muscle and joint aches and pains with them. And as well, osteoporosis is something really to be looking out for with these aromatase inhibitors.
And how do you manage patients that have the side effects from taking these drugs?
So it's tricky because a lot of the management for the side effects that you see for things like vaginal dryness typically would be things like estrogen, right? Estrogen creams, that kind of thing. But using those kind of products in the setting where you're trying to block estrogen to stop a cancer from growing or coming back kind of defeats the purpose of what you're doing. And so very often the first line to try and manage these side effects is to try and use anything but hormones to see if you can manage it that way. And so for vaginal dryness, it would be things like lubricants. Replens is a really great over-the-counter vaginal lubricant that can be really helpful. For hot flashes, there are some medications that work if kind of environmental things like cooler clothes or cooler temperatures don't help. So things like some of the antidepressants at lower doses can help with that kind of thermoregulation center. And some other drugs like gabapentin you may have heard of, or clonidine.
Okay. And because women, suffer from these side effects, especially in the early period of starting these hormonal therapies, one question is around how safe is it to go off these hormone treatments after 5 years if someone is struggling with its, before the 5 years, I guess, if somebody is struggling with its side effects? Like, I guess they want to know the consequences of going off.
So, and it depends a lot on the situation, right? So some early stage breast cancer is you may have done something like Oncotype DX where you're looking at your risk, and that your oncologist may have said, you know what, you're not going to get a whole lot of benefit from chemo. Most of your benefit is going to be from the endocrine or hormonal therapy. And so if you hadn't had any chemo and all of your treatment is that endocrine therapy, there's a higher risk certainly for coming off of it. The numbers in terms of tamoxifen, the reduction in recurrence is about it's in the 30%. It's about 39% is the reduction in recurrence, and the aromatase inhibitors are another 10% beyond that. So that's the benefit you're gaining from those drugs. Typically, the length of treatment is 5 years, and so going off earlier than that, nobody can kind of say, okay, your risk is, you will have reduced your risk by X. But I think there's a few different ways you can approach this, because these drugs can be really, really hard to take. They really throw you. You may have gone through chemo, which has kind of thrown you into menopause, and then you add this on. It's a lot to take really quickly for your body. And so if you're really struggling, things like talking to your oncologist, there's 3 different aromatase inhibitors. Perhaps a different one might be easier for you to tolerate. Some women have gone kind of every other day with their aromatase inhibitor until they kind of get used to it, and then try and take it every day. And the other option would be if you are on an aromatase inhibitor and it's just too tough, maybe you might manage to take tamoxifen instead, which still has some benefit, not quite as much, but still lots of benefit. So I think if you're really struggling, that's a discussion to sit down and have with your oncologist, because there are things you can do, ways around it, but really, typically we try and the accepted duration of treatment is about 5 years for these drugs. And so that's the goal, is to try and stay on them for 5 years.
Well, that's excellent. That really, really is excellent, because I know lots of women struggle and struggle enough that they don't even present it to their physician. So I would say, and I think you would agree, that they be honest and they come forward, and like you said, there are ways to work around it. So that's the most important thing, is not to hide it, and to come forward and to see what there could be, if there's something that could be done.
I mean, I think that the number I've heard is that the compliance is what it's called,
Yes.
is only about 70%. So only about 70% of women manage to stay on their aromatase inhibitors because of side effects.
Right.
So that's pretty significant. If that's your only treatment you're getting for your breast cancer and you're not taking it, that's something that your doctor needs to know. And I don't think there should be any guilt or shame or anything like that in saying you can't manage it, because they're not easy drugs. And there's things that can be done to make it more manageable.
That's right. That's right. Very good. Okay, so I'm gonna hand it over to Bakun, because we'd like to take some start taking some live questions.
Thanks, Kathy. So on the topic of tamoxifen, someone's asking, and this is kind of related to recurrence. So they're asking, would the combination of tamoxifen and solidex reduce the chances of recurrence more than if they just took tamoxifen alone?
So Zoladex is what's called a GnRH agonist. So what it does is it goes to the pituitary in the brain, and it blocks the actual signals from the brain to your ovaries to create estrogen. So it's a very, very powerful drug. It's probably more powerful than tamoxifen or aromatase inhibitors. But so yes, it can be used additively in the setting of tamoxifen if you do wish to get some extra benefit. I don't know offhand what that percentage would be. The most common time we actually see it used, if you're a premenopausal woman, it's not safe to take aromatase inhibitors. And the reason there is because the aromatase inhibitors are looking at that peripheral creation of estrogen, so the creation of estrogen by your fat cells. And if your ovaries are still functioning and you shut off that peripheral source of estrogen, what actually happens is your ovaries say, hey, there's not enough estrogen in your body, we're going to crank out some more estrogen. And so if you're premenopausal and you're on an aromatase inhibitor, you actually increase your estrogen in your body. And so typically only people who are postmenopausal can take that aromatase inhibitor. So what sometimes happens if someone has a very high risk breast cancer and they're premenopausal and you want to get them that extra kind of 10% benefit, then you could shut down their ovaries with that Zoladex and add on the aromatase inhibitor. So that's the more typical combination.
Perfect. And then kind of related to side effects and patients not being able to handle some of the side effects that come with some of these treatments. Someone's asking about passion flower as alternative to letrozole. So I don't know if you've heard about passion flower, but if you have, do you know any information about it being used as an alternative?
I don't know anything about passion flower. I'd be very, very careful. You don't want to take risks when you're talking about your endocrine therapy, especially if that's your only treatment for your breast cancer. And so I'd want to know that there were good randomized controlled trials of that drug. And that's not something that I'm aware of. So you'd have to really look into it and see if there's a scientific basis.
Perfect.
Is that a drug, or is that an alternative medicine?
I'm not too sure. They just said that they've heard passion flower is good for controlling bad estrogen and not harming the good of estrogen.
I don't think there's any evidence for that. And I call natural products drugs because they are, right? They are, a lot of our drugs we use in medicine came from natural places, like Taxols came from the yew tree, right? So I think we have to think of natural products as drugs because they are. And so they have their own side effects, they have their own risk benefit. But you really need to have good evidence that something's going to work to use it.
For sure. Kathy, why don't we kick it back to you?
Sure. So again, it's regarding the hormone therapies. A question is regarding prescribing low-dose vaginal estrogen to alleviate repeated UTIs and pain to a hormone-positive breast cancer survivor who is not on a hormone therapy. So how do you address that?
So this is a question that comes up. Certainly when we talked about this before, the vaginal dryness, I talked about using kind of non-pharmacologic means first off. And I think that's always the go-to. There's a lot of debate around whether you can use any vaginal estrogens to help offset some of these side effects. And anytime you're using an estrogen, whether it's a tablet, like a systemic, or a vaginal, you have to be so cautious in this situation, because the whole goal of the endocrine therapy is to take that light switch and shut it off. And anytime you're taking any kind of estrogen preparation, you have the potential that you're turning that switch back on again. And so again, that's a question to take to your oncologist. But I think for some basic principles, oral endocrine therapy, so oral hormone therapy, like oral estrogen, is absolutely contraindicated, that you should not take, because that would just completely nullify the endocrine therapy that you're taking. In terms of vaginal estrogen preparations, there's lots of debate about it. There's lots of studies that kind of go either way. I have seen some studies that say that with rings and with cream, there's a lot of systemic absorption, and so those are for sure not safe. And perhaps the only one that might possibly be safe are the Vagifem tablets. But again, that's an individual risk-benefit analysis. And I think it's a discussion with your oncologist around what was the risk of your breast cancer? Was it a really low risk breast cancer, or is it a really high risk where you're really worried about recurrence? And how bad are the symptoms you're having? Are they tolerable, or are they kind of ruining your life? And you would be willing to accept some slight increase in risk for the breast cancer. So no estrogen preparation is zero risk. There is for sure risk with all of them. And so it has to be a one-on-one discussion with your oncologist to figure out what the best thing for you is.
And would someone have accessibility to this without a prescription, or?
No, it's a prescription.
Right.
Right. So you would have to go talk to a doctor about it.
Okay. So
Which
there's
is a good thing. You should be talking to someone. This is not something you should be doing independently. So by no means am I saying go ahead and take estrogen. That's not what I'm saying. I'm saying that any estrogen that you take does have risk, absolutely. And it goes against what you're trying to do by turning off that light switch with your endocrine therapy. And so it has to be a risk-benefit analysis.
Okay, great. So I have another question. It's someone who has had a double mastectomy 2 years ago, and she's learned that there are no follow-up scans. Would it be helpful to have an MRI of my chest and under my arms where there was cancer in the lymph nodes? So it sounds to me she had double mastectomy, there was cancer in the lymph nodes, and her treatment plan forward is no scans for follow-up.
Right. So I guess this gets to kind of what is the recommended follow-up for breast cancer. And I think we'll get to the imaging in a minute, but imaging is only part of your recommended follow-up. There's so much more than that. And I think sometimes we get focused on the imaging and forget about the other parts, which can be much more important for many women. So things to think about. Typical recommendations are once a month. Sorry, I think, am I frozen here?
No, you're good.
You're back.
Okay, looks like I was frozen. So the recommendations for follow-up are that once a month, you do a chest wall exam or a breast exam, and you do an exam of your lymph nodes. So those are the lymph nodes above the collarbone, below the collarbone, in the axilla or the armpit. And you're feeling for any new lumps or bumps, any new skin changes, anything that's different. And you are often the best judge of that, because you know your body, you know what it's like post-surgery, you know what's normal for you. Every 6 months, you should have a visit with your either your family doctor or your oncologist, and they should do that exam as well. The other thing you should be doing, and sort of continually, is being aware of new signs and symptoms that you might have. And so knowing about what might be a recurrence or what might be a symptom of a recurrence is really important. And I think the key phrase that I use there for patients is, it's a symptom that is new, that comes and stays for over 2 weeks and doesn't go away. So a new pain that you don't know why it's there and it's not going away, new shortness of breath, new belly swelling, new skin changes, all of those things. So that's the first part, is you are sort of surveilling for all that stuff on your side of things, and having a physician check things regularly. In terms of imaging recommendations, the recommendations are a yearly diagnostic mammogram. But if you've had a double mastectomy, like you say, then you would not do a mammogram, because there's nothing left to do a mammogram on, obviously. There are not recommendations. There's no recommendations for ultrasounds, for MRIs, anything like that. And the reason that is because if you've had a double mastectomy, the breast tissue is gone. The only time when there might be breast tissue left is if you've had an autologous reconstruction. So if a nipple sparing, where the nipples are still there, and some you've had a flap to reconstruct. In terms of why no MRI or why no other imaging, that's really because there's been a number of studies. The most recent one, I think, was 2019, that showed that MRIs, what they do is increase the rate of biopsies by 2, but find no more cancers. And so a mammogram is a good test for this going forward. The other thing to be aware of is you may be a candidate, depending on your risk and your breast density, for either, if you live in Ontario, I'm assuming this is women across the country we're speaking to. If you live in Ontario, there's a high risk program. And so I really suggest that all women know about the IBIS tool. I don't know if you've heard of that before. It's the IBIS. You can put breast risk screening tool. If you put that into your computer and bring it up, it's going to show you, it's going to kind of how you mark off all of your risk factors, and it'll give you a lifetime risk. And if your lifetime risk is greater than 25% in Ontario, then you qualify for high-risk breast screening programs, and that includes MRIs. If you have dense breasts, and that's a whole other topic. I don't know if you want to stop here or you want me to keep going.
You could go ahead.
Yeah, we did have a few questions about surveillance. So I think, yeah, you can just keep
ahead.
going. I'll kind of wrap up all those questions that we get from that.
Good. I don't want to talk too much. If you have dense breasts, so that's category C, category D breasts, you should be doing that same IBIS risk assessment. And if your risk is greater than 15% lifetime risk, then you should be talking to your doctor about supplemental screening. And so that means essentially supplemental screening with ultrasound, or in some areas that's accessing MRI as well. So it's not a straightforward thing, but there's certainly some nuances to it. But I think as a woman, you can kind of know your individual risk, and you can be aware of your own body and any changes that are going on, and bring those to the attention of your physician if you're seeing anything.
Just to follow up on what you said early on, regarding self-examination. So there's been back and forth on this, where years ago they'd say, you need to do this. This is a good way to, and they would show women and all that stuff. And then they decided, no, lots of.
But this is different.
Yes.
So we're not talking self-examination for everybody. So you're right. Breast self-exam is not really suggested, although I still think it's a good thing, because you know your breasts and you know when something changes.
Right.
But in a survivorship setting, it's very different. This is totally recommended and totally acknowledged as being beneficial, because you're going to have scar tissue. You know what your scar tissue feels like. You can see if something's different. The best way to do self-exam, do it on, put it in your calendar, first of the month, whatever factor makes you remember it. Do it in the shower, because it's easier to move your hand around and find things. but it is certainly advised for breast cancer survivors. That's different than just sort of generalized screening.
Even with double mastectomies?
Yes, because you're doing a chest wall exam.
Okay.
So you're feeling to see, are there any new lumps or bumps or skin changes? Are there any changes in the scar tissue?
Okay.
And you're also checking those lymph nodes under your arm. So if something changes, you need to bring that to someone's attention. But that's probably more effective than an ultrasound only every year. If you're checking it kind of once a month, you're going to find something more quickly.
Okay, great. I'm going to send it over to Bakun to answer some live questions.
For sure. And just for everyone, I've put in the chat, because we do have a lot of questions on follow-up and surveillance and all that. So I've put one of our advocacy guides that we did last year, and it talks all about follow-up and surveillance care for someone who's already had a breast cancer diagnosis. So I would suggest reading up on that for any specific questions you might have about certain types of tests.
And that, I don't know if people got the name of that risk calculator.
Yeah, do you have this? I can add that.
IBIS.
IBIS.
If you type in IBS breast cancer, you'll pull it up right away into Google.
So I'll add that in the chat as well. A question that we have here. Someone's asking, do I need estrogen inhibitor if I've had a hysterectomy?
So again, depends first of all on your type of breast cancer. So only breast cancers that are hormone positive, so that's ER/PR positive, benefit from endocrine therapy. Secondly, with your hysterectomy, lots of hysterectomies, they leave the ovaries in situ, or they might leave one ovary. And so you'd have to know, do you have ovaries or not? Because it's the ovaries that create the estrogen. Even if you don't have ovaries, your fat cells, your peripheral fat cells still make some estrogen. And so there would still be some small benefit to being on one of these hormone blockers, but not to the same extent as someone who has intact ovaries.
Perfect. So someone asks, I'm a newly diagnosed premenopausal woman. She had HR positive breast cancer, and I'm about to start tamoxifen after radiation. What should I be doing for birth control?
Really good question. Really important to be thinking about. Lots of women, when they go through chemotherapy or radiation, not radiation as much, but chemotherapy, find that they are automatically kind of kicked into menopause. So the sort of premature menopause rate is about 90% for women who have chemo, but not everybody does. You would not want to be using a birth control pill because that is estrogen based. You'd be wanting a non-hormonal type of birth control. So that could be condoms. You could see if your partner might be open to a vasectomy if you're kind of in that mindset. And the other thing might be a copper IUD. So an IUD that has no hormones associated with it.
Perfect. And then I think something that a lot of patients go through is the tiredness and especially fatigue. So what can patients do to address this?
So first off, I would say you want to make sure there's no medical reason for the fatigue. So the fatigue in and itself is sort of this, and especially after cancer therapy, is this feeling of no matter how much sleep you get, you just can't get your energy back. You're always tired, you're always fatigued, you're not able to kind of get to where you want to kind of feel energy-wise. First thing would be to make sure there's no physical reason. So is your thyroid okay? Are you anemic? It's not because there's cancer back or anything like that. But if you've ruled out all the medical issues, then it's really a matter of kind of knowing your body, knowing yourself, really eating well, watching your alcohol intake, trying to exercise in very small amounts, because as much as that seems counterintuitive, exercise really does help with fatigue post-cancer treatment. And I think kind of looking at what you're doing with respect to the activities you're trying to do and just really trying to kind of partition them out and figure out what's feasible for you to do on that day.
Mhm. Perfect. And then I'll ask one last question before we go back to the pre-submitted ones. So you spoke a little bit about exercise. Can you tell us a little bit more about what types of exercise would be helpful?
Sure. So exercise, interestingly, has an effect to prevent breast cancer recurrence, almost on par with tamoxifen and some of these other things we've been talking about. It causes the risk of breast cancer recurrence to go down by about 30%. So that's pretty high. And it's somewhere between 25 and 30%. The definition of exercise is that you're doing 150 minutes of kind of moderate intensity exercise per week. And so that really means what I tell my patients is use the talk test. So if you're walking with someone else, are you able to keep carrying on a conversation? Because if you can carry on a normal conversation, you're not working hard enough. Like, you need to be exercising to a level that it would be hard for you to kind of keep talking. It looks like strength training and weights and that kind of stuff doesn't seem to have quite the same benefit that can be documented, but certainly sort of vigorous aerobic exercise, 150 minutes a week, is really kind of the mainstay, not only for preventing recurrence, but for a lot of the symptoms that come up, like fatigue, like fear of recurrence, anxiety, depression, all of those things. It's a really great tool to help manage those things.
Perfect. Kathy?
Yeah, so I'm just a little bit back on the exercise. Do you think walking every day? Some people are asked, what about walking every day for half an hour, and just keeping active? Is there been?
Absolutely. Yes.
Does
Super
it have to be vigorous? Does it have to be, or is it
right.
just
So,
a constant, level of moving?
so anything is better than sitting all day, right? You want to stay active, you want to keep busy. So walking is great because walking means you're not sitting, right? It's that moving away from that sedentary kind of lifestyle that we all end up doing because we're sitting in front of computers. And but clearly the more sort of vigorous the activity, the more benefit. So absolutely walking, but if you can just turn up the speed of that walking a little bit, that'd be great.
And how do you feel about the gadgets that are available to all of us now in terms of the 10,000 steps a day? And some
It's
people
awesome.
very go with that. Like
It's awesome. Whatever you can use to motivate you, any exercise is better than no exercise.
So going back to the word alcohol, where do you see your recommendations? 0, some, none, like, because the controversy is always coming back and forth, and the last indication is like 0 alcohol.
Yes, so alcohol has clearly been linked with increased risk of recurrence. So no alcohol is better than lots of alcohol or some alcohol. But some alcohol is better than lots of alcohol. Certainly the new guidelines say no more than 2 drinks a week, which is a lot different from what we're used to hearing. So I think sticking to that is a really good metric, because it's not just for breast cancer, it's for everything. We know that alcohol causes problems with your liver and your heart. So I think keeping it to a really minimal level is probably the best thing to do.
Okay, so it's not 0 like they recommend.
Would you like me to say it's not 0?
I'm not gonna push it. Let's do 2 drinks.
I think it's, we know that 0 is probably the best. But it's a personal decision. And for lots of people, if they'd like to go socialize with friends, that's part of their mental health. And that's kind of built into that. So I think an awareness that it's a factor that weighs in and you have to be careful of it is important.
Very good. Okay, so I'm going to read another pre-submitted question. So this one reads, given that breast radiologists understand that it is difficult to visibly see breast cancer in a highly dense breast, is there a benefit of having a mammogram after 70 years old for a woman with a previous history of breast cancer and dense breast tissue? It's a big question.
It's a long question. So that I think the question is saying, if you have dense breasts, are mammograms still good to do when you're over 70? And my answer is absolutely. So when we're talking about breast density, there's 4 categories of breast density. There's A, B, C, and D. And C and D are the dense categories. There's dense C and extremely dense D. And the thing about breast density is kind of twofold. It increases your risk of breast cancer by about the equivalent of having a first-degree relative with breast cancer. At the same time, if you've ever seen a mammogram and you've seen a woman with dense breasts, that mammogram looks like a snowstorm. Like there's a lot of white on that picture, and cancers typically show up as white. That's how they show up. So when you're trying to look for cancers on a mammogram with someone with extremely dense breasts, it's the analogy I've heard is it's like trying to find a snowball in a snowstorm. So it can be very difficult. And so we know that mammograms are much more effective in women whose breasts are not dense, so like an A or B, but they still are effective in a C and D. The issue comes that I think if you've had a normal mammogram and you've got dense breasts and you feel something or there's something going on, you have to push for more imaging. So you can't just trust that mammogram. Like we talked about earlier, if you have lots of risk factors and your lifetime risk of breast cancer is, by that calculation, greater than 15%, then you need to look at getting supplemental imaging to go along with that mammogram. So perhaps an ultrasound if it's available for you. There are some provinces where that's done automatically. I think PEI does, if I'm not wrong. And in terms of age is kind of irrelevant in my mind here, because you can have dense breasts when you're young, you can have them when you're old. The issues are the same. It's about the risk of breast cancer and not being able to see them as well. And so breast screening should continue at least till age 74, and even longer if your life expectancy is 10 years. Like if you're pretty healthy otherwise, then you should continue with your breast screening. In this case, we're not really talking about screening. We're talking more about sort of survivorship follow-up. So it's a little different. And in that case, absolutely, you should keep going. So just because your breasts are dense doesn't mean you shouldn't do a mammogram. You should do a mammogram, but you should maybe think about whether you need some other imaging to add to that. And you shouldn't be reassured by a normal mammogram if you're noticing changes in your breast or when you're doing your exam.
So getting back to the cutoff time. So someone with a diagnosis of breast cancer should continue mammograms his or her entire life versus somebody who's not had. Can you clarify that a little bit?
So screening, there's 2 different buckets of things we're talking about here. We're talking about screening, and then we're talking about post-treatment surveillance. So for screening, the ages vary across the country, but it's typically 74 that screening ends, except for in Quebec where it's 69. You're lucky. Quebec does everything a little different.
Maybe not. 69 is quite young to stop.
I know. I actually really disagree with that. And actually, probably if you're a 74-year-old woman and you're doing screening, you should, and you're really well and healthy and you've got this 10-year life expectancy, it makes sense to continue with your screening. If you are in the other bucket of people, so the post-treatment surveillance, you just keep going with your yearly mammogram. And the time to stop would be if you have a lot of other medical issues, which would mean that you wouldn't be a candidate for any treatment because you've got other things that are bigger problems for you than a recurrence.
Okay. Because that's a little unclear sometimes. I think it varies. But thank you. That's very good, the way you clarified that. Have another submitted question. This person said she was diagnosed with early stage lobular breast cancer 20 years ago and had an early stage recurrence 2 years ago. Are there different models for follow-up care for patients with recurring breast cancer. So lobular, don't they usually have mastectomies?
Depends a lot. It depends, was it a lobular in situ? Was it a, like, what, how big? I don't know, right? I don't know enough about the case. But I think the question really here is, if you've had a recurrence, is your follow-up different than someone who hasn't? Regardless, I think, of the lobular or ductal question. It's not different, your follow-up. But I think if you plugged that into that IBIS risk calculator, you'd be finding pretty soon that your risk would be kind of more escalated, and you might be more, certainly if you live in Ontario, you'd be more likely to be entering into the high risk program.
Okay, great. Bakun, let's take some more live questions.
Sure. So we have two questions about dental work and treatment, but they're both about two different types of treatment. So I'll just put them in one question. So can you speak a little bit more about taking certain treatments, and if you can stop them when you're doing dental work? How does it impact dental work or possible blood infections?
So there's, do they specify the kinds of treatments?
Yeah, so one of them is letrozole. So they were saying they're taking letrozole and they had 3 teeth removed. The other one was taking tamoxifen, and their endodontist suggested going off tamoxifen for a week to 10 days after each tooth removal. So I guess it's trying to look at, is it safe to go off these type of treatments when they're doing dental work? Do they have to worry about doing dental work?
Gotcha.
Yeah.
Okay. So again, when I think about cancer treatment and dental work, I'm thinking in bucket. I like to think in buckets. There's the chemo, right, where for sure there's a risk of dental work because your blood counts go down, you're more at risk for infection. So that isn't in and of itself, that's a bigger thing. The other class of drugs that really impact dental work are the bisphosphonates. And there's lots of women who will be given bisphosphonates if you have ER positive disease as an adjuvant or adjunctive treatment. And often those women get 2 years of, you may have heard of Zometa is one of them. Those medications put you at really high risk for osteonecrosis of the jaw if you undergo dental work while you're on them. And so you should, if you're on a bisphosphonate or, if you're on a bisphosphonate, you need to let your dentist know, and you need to work that out with your dentist because they'll know what to do about those, but you do have to flag that. Endocrine therapy, I'm not aware of needing to stop those drugs for dental work because they don't make your counts go down. Some targeted therapies can make your counts go down, but not endocrine therapy. But I'm not a dentist, so I don't know about that actually. In terms of staying off it for a week to do some dental work, that's fine. That it's not like you're going off it for this prolonged period. I think that wouldn't increase your risk of recurrence if that's what you needed to do.
Perfect. And someone actually spoke about Zometa, and they said that they've seen slower healing since they've been on it. Does it increase? I get you spoke a little bit more about this, but can you talk a little bit more about the risk of infection and if, like, how cancer impacts someone's teeth?
You're really making me work here. So Zometa does not increase your risk of infection. Zometa is a medication that targets your bone. And within your bone, you have 2 kinds of cells. You have the osteoblasts that build your bones, and you have the osteoclasts that kind of break down your bones. And bones are always turning over. That's a healthy thing. And it's a balance between these kind of 2 cells. For drugs like Zometa, what you're essentially doing is putting a leash on those osteoclasts so they can't break down your bone as much. So you're not forming new bone, and your bone's not turning over in the same way. The reason that they're used in breast cancer treatment is because they've been shown to reduce the risk of in-bone recurrence many years hence. And so they're used typically in quite high risk scenarios. Not everyone would be on these drugs, and they're typically given for 2 years. There are also drugs that are used for treatment of osteoporosis. And so given that aromatase inhibitors can cause osteoporosis, that there's sort of this bonus there of building your bones back up. The risk of these kinds of drugs is osteonecrosis of the jaw, which basically means if you have dental work in the jaw, your bone doesn't kind of heal, and you end up with kind of chronic or long issues within your mouth where you might have exposed bone that take a long time to heal. And so that's why it's really, really important to kind of let your dentist know if you're on any of these drugs. But in terms of general healing, like skin cuts, that kind of thing, wouldn't be impacting that at all.
Okay. And then similar to kind of being immunocompromised or how things impact someone's immune system. So someone caught COVID for the first time last month, just before their radiation was about to start. So they want to know if their treatment, specifically radiation and endocrine therapy, puts them at higher risk of having a compromised immune system.
So endocrine therapy, no. Does not compromise your immune system. Radiation therapy can compromise your immune system if you're getting large portions of your bone radiated. And the reason I say that is because it's your bone that creates your blood cells. And when you get radiation to, say, your pelvis or areas like that, you slow that creation of blood cells within the bone marrow. So typically breast cancer treatment or radiation is only to the breast. You're not targeting those big areas of bone, so should not significantly cause immunosuppression.
Perfect. Someone's asking about the Signatera test. Do you think it's a helpful tool after chemo or radiation?
I don't know enough about that one to be able to comment.
No problem. And then kind of going back to when we were speaking about side effects and, the side effects of certain therapies not being manageable for patients. Do you have any, I guess, like suggestions that you'll speak to patients about of when to switch pills? Like, if they have certain side effects, do you get to a point where like, okay, maybe you should consider speaking to your oncologist about, trying a different pill? So specifically, this person is on an exemestane, and they are unable to stop gaining weight, even though they're working out, eating healthy. So they're wondering, should they be looking into switching pills?
I don't know that switching would, like, weight gain is not typically a reason that people switch. It's more sort of intractable issues with aches and pains, or that's the most common reason that people would switch. There's arthralgias, they're called, and myalgias. I have the sense that probably all of the endocrine therapies might have that same issue for this patient, and so I don't know that switching would be beneficial in this scenario.
Mm-hmm. Perfect. Kathy?
Okay, so we'll go back to the pre-submitted questions. I have a question here. This woman writes that she's had 2 lumpectomies, ultimately and happily resulting in a diagnosis of negative for in situ and invasive carcinoma, and the incision of ALH cells, which means that they're cells that are not cancer yet. I'm now referred to a cancer center for preventative oncology to lower risk of recurrence, possibly radiation and tamoxifen or similar. Can you explain how this level of treatment varies from that which treats cancer cell tumors? So she's asking, what is the difference treating her versus someone who has been diagnosed with cancer?
And I think that's the very first take-home message here is you do not have cancer, right? If you have, so ALH is, it's lobular hyperplasia, right? So there's some pre-cancerous changes. So we know that in many different cancers, there's sort of these gradual stages that things start to sort of change very gradually and evolve over the time and eventually become an invasive cancer. And so if you can catch these things early on, you catch them before they're invasive, before they're actually a cancer. So in terms of treatment, it's a whole lot different because you're not treating an invasive cancer, you're treating a kind of a pre-cancerous lesion. And so you're looking for risk reduction more than anything else, because having ALH does put you at increased risk for development of cancer in the future. So what's most commonly would be talked about here would be chemo prophylaxis or chemo prevention, meaning using tamoxifen in a preventative manner. So when it's a misnomer because we're not talking about using chemotherapy. So an invasive cancer would be typically treated with surgery, plus or minus chemo, plus or minus radiation, plus or minus endocrine therapy. Like there's a whole number of steps. For this kind of scenario, you've had the area removed, and then you might talk about going on tamoxifen prophylactically, if you will. And tamoxifen in this setting, if you take it for 5 years, really reduces the chance of developing a cancer down the road, probably by around 75%.
Now, are these cells typically hormonal dependent? How would one know?
So not necessarily, but they've done trials where they've looked at tamoxifen in this setting, and it is particularly effective for this lobular hyperplasia, regardless of endocrine status.
Interesting. Thank you. So this other question, this person made a decision to go off hormone blockers because of side effects. It was a hard decision, but she put quality of life ahead of, the symptoms, I guess. Are there health measures or nutritional means that can reduce my chance of another cancer? I have already lessened my sugar, red meat, and alcohol intake. So I guess she's wondering, what could she do, seeing that she's decided to go off? It's something,
and it's not an easy decision to go off, right? This is such a difficult call because there's so much guilt, and it's not an easy decision. So number one, I would make sure that you've had that discussion with your oncologist about, are there any other options? Could I be on, say, tamoxifen instead of an aromatase inhibitor? In terms of reducing your risk, I think you're doing all the right things. So eating healthy, managing your alcohol intake, exercise, don't smoke. The other thing that breast cancer survivors often don't do is they get so fixated on or their GPs are kind of thinking about the breast cancer, and we forget to do stool tests to look for colon cancer. We forget to do pap tests to look for cervical cancer. So make sure your other screening is up to date as well. I think the stats are only in one study, only about 35% of breast cancer survivors had up-to-date stool testing for colon cancer, and only about 65% had up-to-date pap tests. So that gets lost, I find, sometimes. And so keeping up with that kind of stuff is important as well.
Okay, so patients should ask to have these things done, because I guess the oncologist automatically assumes that you're being followed for all the other.
So what happens often is you're so busy seeing your oncologist that you don't really see your family doc, and your oncologist they do not do cancer screening beyond, they just are managing their breast cancer. That's their job, that's their role. They should not be doing the other stuff. But the other stuff kind of gets forgotten because you're so busy with everything else that's going on. So that's your family doc that orders your screening, and just make sure that you're up to date on all that stuff.
Bakun.
Yes. So speaking of being followed up, someone was prescribed anastrozole for the next 4 years, and they want to know what happens after that. So after the 4 years, would they be reviewed with their GP or their oncologist in terms of deciding whether they continue on anastrozole or not?
So it varies. So typically, patients do 5 years of endocrine therapy. If you're very high risk, you might do 7 years. And if you're super high risk, some people do up to 10 years, although there's no benefit really beyond 7 years. The way that people are followed, and I think, first of all, at that 5-year point, it's a discussion with the oncologist. Am I good? Or, should I be doing more? in terms of who follows you long term, that really varies from center to center. And in some centers, like in Ottawa, we have a Wellness Beyond Cancer Center where they might see you and kind of follow sometimes just the higher risk patients. But typically people are being referred back to their family doctors because there's just not the capacity within cancer centers to be seeing all the survivors plus all the new patients coming in. And honestly, family doctors are the better people to be doing your care at that time, because your family doctor is thinking about your pap test and all your other issues at that point. So it really depends center by center who follows you longer term. But ultimately, it will probably be your family doctor with direction from your oncologist. And family doctors typically have, a way to get you back into the system if they need to. So it's not a bad thing to not be followed through the cancer center, because there is that sort of escape valve back in there if you need it.
And then this is specifically about letrozole, but just in general, when patients are going through side effects, the severity of it, does it kind of continue long term, or does it get less? So this person's asking specifically, will the hot flashes calm down over time? But can you speak to, I guess, side effects generally? Do they kind of get a little bit less as time goes on, or you find that it's kind of that same severity throughout?
So for sure, there's an adjustment phase when your body's getting used to it, and it's a big change, and you're navigating that. I think it's an individual thing. Some people find that they get through that first kind of few months and things settle out, and they're more comfortable on it. They're doing okay. Some women find that it doesn't sort of get easier for them. So I don't think there's a one answer fits all there.
Okay. How would someone address pain even when they're using a lubricant?
So vaginal pain?
I'm thinking so.
Yeah.
Yeah, they didn't specify, but I think so. Yeah.
Right. So one of the issues when you have vaginal dryness is painful intercourse. And so like the question said, you can use lubricant, those kinds of things. If you're still having pain beyond that, there's a few things you can think about. So pelvic floor physio can be really helpful. Just kind of relaxing the muscles down there and kind of helping you manage that, having more control over that. The other piece of that kind of is part of this too, that comes along with the endocrine blockade and the whole treatment, is the whole feeling of sort of decreased libido and decreased sexuality, because your body's changed and things are different, and it's been a difficult time for your relationship. So it's all of those, it's a holistic thing, right? It's all of those factors that you have to be addressing. Is your relationship good? Are you comfortable with your partner? Have you feeling like they've been supportive with this or not? Or so trying to work through all that stuff as well, I think, can ultimately help. But sometimes it's just a physical issue, and that might be when, if it's really profoundly dry and you're really having troubles, that might be when you have that discussion with your oncologist. Is there anything you can do?
Perfect. Kathy, back to you.
Sure. So this next question is around hormone therapies, obviously, this is a big topic today, such as letrozole. They want to know, is there any test that will indicate whether or not the therapy is working?
So we do not check hormone levels or estrogen levels when you're on these. And there's no need to. We know that they block your hormones, that's why people are having all these side effects, right? Because they work. So no, there's no test. You just go on them and you stay on them as much as you can manage it. And then when you've done your time, you're done.
I guess the symptoms describe it all.
I mean, I don't think you need a test. I think the symptoms are your test, right?
Something's doing something in there.
Well, and maybe if that helps you manage the symptoms, if you can psychologically say, you know what, this means it's working, like maybe that's a way to manage it, right?
Right. But it's a good question, I guess. If you're not having that big a symptom, this is a question that might arise. I have another question is, how often should someone who is treated for TNBC, triple negative breast cancer, and achieved NED, no evidence of disease at lumpectomy, be scanned or monitored?
So I guess the root of this question is probably that triple negative cancers tend to be more aggressive than some of the hormone positive cancers. And so I guess the question is sort of saying, is there a different follow-up if it's felt that this cancer is more aggressive? But there's not. The follow-up is the same for breast cancer, no matter what the subtype. Same with HER2 positive. It's the same, monthly breast or chest wall exam, 6 monthly clinician exam, watch for symptoms of recurrence, know your body, know what's changed, know what's different, and have your mammogram every year. If you are sort of high risk enough, then maybe you would qualify for other screening as well.
Great. So if we're going to move outside the hormonal therapy area,
We're going to leave the hormone therapy.
for now, I'd like to address anxiety, fear of recurrence. So I would imagine that you must take care of some of these individuals who have had breast cancer and now are living with the, living post breast cancer. And obviously there's anxiety and fear that in some people doesn't go away ever, even years and decades later. There's always something in the news. And now, early stage breast cancers are recurring later on. So there's always something that, they're alerted by. So how do you, manage individuals who have these anxieties and fears?
I mean, I think the first thing is to acknowledge them, right? That you've been through something really traumatic and really difficult, that you've had to sort of question. It's probably changed your life entirely, and I mean, I'm only imagining what breast cancer survivors have been through, because I've walked patients through the treatment, I've helped prescribe chemo, I've watched them, and I've never been through it myself, but it's not an easy journey by any means. And I think the knowledge that this could come back someday is very difficult. And I think it's a very reasonable fear given what you've been through. So I think it's very natural and normal to feel that way. I think one of the ways of thinking about it is knowing that the time when most recurrences happen is in the first 2 to 3 years after treatment. So if you've moved beyond that, I think you can start to kind of feel some ease a little bit, although obviously the risk of recurrence is never zero, but it's certainly way higher in those first few years. So I think you can use that to kind of walk yourself through it. And I think you can kind of take control of the situation and say, you know what, if I'm worried about recurrence, here's what I'm going to do. I'm going to do my monthly check. I'm going to think about, be aware of my body, be aware of symptoms. I think you have to have outlets. So, and your outlet shouldn't be alcohol, right? It should be exercise, because we know exercise is just as effective as something like tamoxifen. So use that as a way to kind of deal with your fear. Have really good friends, have a supportive partner, talk it through, have supports that way. If you need a psychologist to help, then that's very reasonable. And know when that fear is incapacitating. So if that fear is stopping you from functioning every day, then maybe it's beyond just kind of a fear, and maybe it's more sort of shifted into an anxiety disorder where maybe an anti-anxiety medication might help. But it's a very, very reasonable thing to have that fear.
And how do you discuss these, this perfect answer and trying to manage it yourself, a person trying to manage it with somebody that they're living with, like their partner or their family or their children? Is it a good thing to bring your family members to discuss it? Because the caregivers have a very important role in helping an individual. So how do you?
I think it depends. So some relationships are very open. It's very easy for people to speak with their significant other, and they feel very well supported, and that's that's great. But if you feel like you're not able to communicate and you're not able to say the things you need to say, then maybe bringing your partner along to sort of engage in discussion around it might be helpful. That's where maybe a psychologist would really be helpful in terms of, because it certainly creates stresses in relationships. And so kind of addressing those and the basis for it. But I don't think there's a one answer there.
No. And do you think that years down the road, it gets better for some people, most people?
That's what I've seen, is that
Yeah.
people who are many, many years out, sort of each year, it's that memory of going through that is, you know, the human body is an amazing thing. We kind of shut out the things that are really bad, right? And you kind of, as you move from it, I've seen that people who are further along, it's less and less of a fear and a focus.
Right, right. And what about comorbidities? How does a family doctor help a patient that is currently just off of, finishing treatment with cancer and now is in survivorship and they have comorbidities? How much can somebody have on their plate, and how does a family doctor help in this area?
So when you're saying comorbidities, I'm assuming things like high blood pressure, diabetes, those kinds of things.
Yes.
And the thing about these things are all interconnected. So, sometimes your blood pressure might have been impacted by your treatment. Certainly with the aromatase inhibitors, they can make your cholesterol go up. So maybe that's playing in a little bit as well. But family doctors, what they do is take care of the whole person. So, they're going to look at each of those things and make sure they're equally managed. But it's not seeing you as medical issues, but seeing you as a person. And how do we take care of you?
Great. Bakun, I'm going to send it off to you.
Perfect. So I'm going to bring us back to hormone therapies. But I think this is a very important question. So this person is 42 years old, and they had their ovaries removed at 40 due to a strong recommendation, and then so that they could take letrozole. So they want to know if you can speak a little bit more about the serious serious effects of becoming postmenopausal at such a young age. Specifically, they're wondering about their expected lifespan. Like, does it get impacted because they had their ovaries removed? And then a kind of a follow-up to it. So when they're looking at age-based recommendations, for example, how many calories they need to eat, should they be following guidelines based on their actual age, or should they be treating themselves as a senior citizen because
No, absolutely not. You're 40, you're not a senior citizen. Absolutely not. Doesn't matter if you have your ovaries or not. So yes, so removing your ovaries puts you into menopause, but it does not affect your chronological age. So you are still the age you are. In terms of medical risks, the major issue would be in terms of osteoporosis, right? And especially if you are on an aromatase inhibitor, those drugs in and of themselves cause osteoporosis. So you kind of have a double whammy there. So I would do everything that you would normally do as a 40-year-old. You are not a senior citizen by any way, shape, or form, but you should pay attention to your bone health. And so what that means is you should get enough calcium in your diet. I really like osteoporosis.ca has a calcium calculator that you can pull up, and you can put in essentially a sample of your dietary intake for a day, and it'll tell you how much calcium you're getting in your diet, because there's calcium in lots more things than just milk and cheese. There's calcium in broccoli and all kinds of things. So make sure you're getting enough calcium. You should be getting 1,500 milligrams of calcium a day. Take enough vitamin D, so 1,000 international units of vitamin D a day. Get weight-bearing exercise. So that is exercise like walking, where you're, we talked earlier about those osteoblasts and osteoclasts. When you have weight-bearing exercise, it prompts those little cells to get working and rebuild your bones and make them stronger. So lots of weight-bearing exercise. And then you should be having bone densities. And a bone mineral density looks at the strength of your bones and can tell you if you have osteoporosis or not. And so that's something when you're on an aromatase inhibitor, part of your survivorship care is you should have a bone mineral density every 2 years. And based on what your risk comes back at, you may be suggested to go on a bone building medication that can help beyond the calcium vitamin D.
I'm wondering if you could speak about complete response after neoadjuvant chemotherapy. So this person has heard mixed studies about this, where some people say that complete response for this doesn't mean that recurrence is lower. It just means that the medication worked well. So do you have any thoughts to share about complete response?
I mean, I'm not an oncologist, so I do not pretend to be an expert in this area. But typically, patients who have a complete response do better in the long term. Patients who don't have a complete response often have to go on and do further chemotherapy to look at treating the cancer that they're treating. So I don't actually know the figures offhand or the studies, but I do know that it is a good prognostic sign.
And then do you have any practical tips for someone to distinguish between a potentially cancerous lump along mastectomy scars versus just scar tissue? Like, how can they tell the difference?
So I think the biggest way to tell the difference is it new and is it changing? So your scar should be your scar, and your scar should over time soften a little bit, get a little bit less prominent and obvious, but it should not be getting bigger. It should not be changing in shape or size or color. So if there are changes in that scar, you do want to get them looked at. And that would be the best way to be thinking about it.
Mm-hmm. Kathy?
Sure. Long question. After having breast cancer recurrence, this woman's been told that it's not if it comes back, but when it comes back, and that it will either be going into, I guess, metastases to the bones, the lungs, or the brain. All that has been offered for follow-up and surveillance or mammograms once a year and meetings with a nurse practitioner. If the oncologists feel that it will return, why isn't follow-up care more proactive? Should I not be having bone scans, PET scans, marker blood tests, etc.? How will I know if it has returned, and how can I be more proactive about my follow-up? I guess it's in what you've been saying all along, to be more aware of your body and to make sure
there's no changes. Yeah. I mean, first of all, I don't know the individual situation here, so it's really hard to know why that comment was made, but it's very difficult to predict who's going to recur and not recur. So I don't know that just because you've had one recurrence means you're going to have metastatic disease. That sounds unusual to me, but I don't know all the details there, and maybe there's something I'm not knowing in the story. There is no evidence for PET scans, for CT scans, for bone scans, for blood tests, any of that. There is zero evidence that there's benefit in the survivorship phase. So again, I think, like we talked about, it's being aware of your body, noting any changes, figuring out if you're high enough risk to access kind of some of those higher risk screening programs. That would be my recommendation there.
And if we speak to the whole idea of having cancer care after you've been diagnosed and finishing your treatment, as we all know, the healthcare system doesn't always provide a easy to get a family physician for everybody. How would one go about making sure that once they're gone from the oncology team to be followed, properly with someone such as yourself, a family physician, if they do not have one? Because some women will get a mammogram, letter saying have a mammogram, and they may not have a physician, and then the ball starts rolling, and then they have no one to turn to. So I know it's going to be different. I know we have a universal healthcare, but it's provincial. We know all that. So how could one make sure that they have a family physician?
I mean, we have a real crisis with access to family medicine. I think in Ontario alone, there's 3 million people who don't have a family physician, and it's only going to get worse before it gets better, is my sense. So it is the reality that there's a lot of people out there without family docs. So what do? In Ottawa, you're lucky because we've created an app, and so you can use the Survivor Advisor. It sends you reminders about what to do. But I think the biggest thing is, so number one, be aware, be your own advocate, know what your recommended follow-up guidelines are, and kind of keep track of it yourself, right? So you know, okay, I'm due for a mammogram, I'm due to be checking myself. So know what your care should be and be advocating that way. If you need a mammogram, in Ontario, it's really difficult because if you're part of the screening program in Ontario, you can get a mammogram without a doctor's requisition. But if you are part of survivorship in Ontario, you cannot get a mammogram without a doctor's requisitions, right? So you're not part of the Ontario breast screening program. And I don't know what the scenario is in other provinces, but I'm assuming it's similar. So you would need to go and find a doctor to get your mammogram for you. And I think your option would probably be a walk-in clinic, which is not ideal by any way, shape, or form, but I think it's the way to go and get a mammogram ordered. And so really knowing that you're due and being self-advocating and going out and seeking those tests is important.
Right.
But it's a problem. It's a huge, huge problem.
Yeah. Because, somebody's listening here, and if they don't have a doctor, they're like, okay, so what do I do? How do I follow up? I mean, I guess the hospital, the cancer care team might try and find them somebody to take care of.
It's really like we cannot, and I know in our hospital we're not able to do that because there are no doctors taking patients. So what's happening at the moment is the Wellness Beyond Cancer Center is printing out the survivorship care plan for the patient. They have that, and just suggesting that you go to a walk-in clinic for the things where you need a doctor. Or patients are getting on the app, so they're getting reminders for these things about when they should be doing what, when.
Yeah, so they should be asking their oncologist before they get discharged to find out which way they can, best find care afterwards. Bakun, do you have any last incoming live questions before we kind of wrap it up?
For sure. So this question is about recurrence. So someone was on tamoxifen for 7 years and their cancer came back after 10. So now they're worried that once they're finished with letrozole, that their cancer will come back. So they'd want to extend how long they're taking letrozole for. So I guess the question is there any benefits or drawbacks from extending how long someone is taking these types of treatments for?
Yeah, so the evidence is really maxes out at 7 years in terms of the benefit. You can extend to 10 years, that's possible, but the harm is that aromatase inhibitors cause osteoporosis. And so if you're on those drugs for a prolonged time, you may really run into troubles with osteoporosis. So you're going to have to be very careful in watching your bone density, making sure that you're not sliding into osteoporosis, and certainly probably wouldn't take beyond 7 years, and definitely would not take beyond 10 years.
Perfect. Kathy, did you want to finish off with any questions that you have so we can wrap up?
I'd like to turn it over to Dr. Wilkinson to give us, what is your best takeaway for patients listening into this session? What is the best way they could take care of themselves? I mean, after we've just realized that there isn't enough doctors for everybody, and how to self-advocate. I mean, there's groups like ourselves, they can come onto our website, and if they have any questions, and, we have a wealth of information if they need anything, but how can somebody be so proactive that they can, at least get their stuff in order?
I mean, I think the bottom line is, and these have all been excellent questions tonight. They're all, I mean, a lot of them have been around endocrine therapy, which I think highlights how difficult it can be to take these drugs. In terms of the overall picture, I think there's a lot of things that you can do independent of the medical system. So kind of like we were saying, exercise is probably the best thing that you can do. Watching how much alcohol, eating well, living well, all of those things are key. I think really being aware of what the survivorship guidelines are so that you know what you need when. And it's really pretty straightforward. It's not complicated. So what we've kind of come back to it a few times, but that monthly check of yourself, being aware of any new symptoms or signs that are popping up, that are staying, that are not going away, that are getting worse. Having a doctor or a nurse practitioner do a physical exam for you every 6 months for the first 3 years, and yearly for the last 2 years, so the 5 years post. A yearly diagnostic mammogram, if applicable for you. And then if you're on aromatase inhibitors, a bone density every couple of years to watch for osteoporosis, get your cholesterol checked because of the potential impact on your cholesterol. So those are the key things. If you're on tamoxifen, be really aware of vaginal bleeding or changes in your bleeding that might suggest that your lining of your uterus is getting too thick. Those are all the key things that I think you can be really aware of. But I think a lot of it is stuff that you don't need a doctor for. A lot of it is just that awareness and knowing what you need and just moving forward with it.
Thank you. Thank you for those final words. So, like we're saying, this brings our session to a close. And I'd like to thank everyone for the excellent questions and for joining us. And thank you, Dr. Wilkinson, for this great and engaging discussion. Thank you to our participants for attending and all the great questions that you asked live and pre-submitted. After this session, you will be sent a survey to provide feedback in this session on this particular session. Please fill out the survey, as your responses help us make these sessions a lot better. And once again, thank you to our sponsors, Viatris, Novartis, Amgen, Gilead, Merck, and Seagen. Thank you, everyone, and have a good evening. Thank you.
Thank you so much.
Thanks, everyone.